short learned video with your permission.
Which video?
A short learned video.
Can you do it at the end?
Yeah, sure. No issues.
Okay,
All right.
please do it at the end. Yeah.
Okay.
Yeah, let's start.
So good evening and welcome to all. This is Ankita, the assigned moderator from Planet. And Planet is very proud to be a part of this webinar. So Planet is India's largest live digital CME. And without any delay, I would like to hand over the session to Dr. Andrila.
Indian Chess Society welcomes you to this webinar. ICS is committed to providing an in-depth understanding with take-home messages at the end of every webinar. This time, we are conducting a series of informative webinars every fortnight. In view of the World Asthma Day, today our discussion is on allergy and essential for an asthma specialist. I welcome our guest speaker, Dr. Shoibal Moitro, Adjunct Professor and Senior Consultant, Division of Allergy and Immunology, Department of Respiratory Medicine, Apollo Multispeciality Hospital, Kolkata, to go ahead and highlight the history, taking an evaluation of respiratory allergy. We welcome you, sir. Over to you.
Thank you, Andrila. I would like to thank the Indian Chess Society for inviting me in this webinar. And I would directly start with my topic so that we can have a good discussion in the end, because we have a very good panel discussion. So is my screen visible?
No, sir, not yet.
Okay. Can you just allow me to share my...
It's already allowed, sir. Can you please go to share screen?
We don't have time. It can go up till 10 also. 9 slots.
Your screen is...
On the Zoom platform itself, like this platform, click on share screen and click on the PPT you want to share, sir.
Just this way.
Sure, sir. No issues.
Yeah, it's there. Yeah, I think it's visible now.
Yes, sir.
Okay, thank you. So whenever there is a legitimate referral for any allergy, for any patient will find that all these referrals are associated mostly with a slew of allergy tests, which might have been done before, or maybe the consultant or the physician who's referring the patient has already advises an allergy test, and the patient comes with the report. So at the time, we have to deduce that what the report is saying, and then we have to amalgamate the things with the history, and then we have to come to a diagnosis. So at times, it becomes a very arduous task, because we need to find out whether the tests were done, whether it was needed, and how do we actually infer from that. It should be remembered that all the tests, that mostly when it is done, when there is not a very specified history, this test has a very low specificity. So that means that lots of false positive results. We all might have seen patients coming with some allergy tests, and which is showing the positive to lots of items which was done. And then the patient is quite bewildered what to do with the result. So this is very important. That's why that we have a very good history, clinical history, before we advise the test for a particular patient. And depending upon the patient's history, we advise the test, we select the allergen panel. And then after the result comes, then again, we have to do a post-test evaluation and correlate the results with the history so that we come to a proper allergy diagnosis. So in this way, if we have a very good history, we increase the pre-test probability of having a disease, then we can have a very good post-test probability. We all have seen the Fagan's nomogram. So it starts with a pre-test probability, then the likelihood ratios, and then the post-test probability. So to have a good post-test probability, that is to have a good positive predictive value, so they can correlate with the history, we should have a very good history. So everything starts with a very good meticulous clinical history in case of the allergy. So that is my talk would be. So these are my disclosures. And objectives would be, we'll be talking in short about what are the demographic parameters we need to focus in the history, how we should detail the symptoms, and a very brief talk about the pollen calendars and how to use it while we're selecting in the allergen panel. And at the same time, we should have a knowledge about the topic march. And then on the basis of everything, we need to select the allergen panel. So obviously, usually we start with the patient's particular name, age, sex, occupation. And this is important because a particular occupation patient may be exposed to a particular allergens. And at the same time, at various ages, we have different allergies. So at this slide, you can see that this is quite an old article, 2013. It shows that this eczema and the food allergies, they are more prevalent in the younger age groups, while the respiratory allergy, the nasopharyngeal allergies, like allergic rhinitis, chronic rhinosinusitis with nasal polyps, or allergic asthma, they are more common in the later age groups. So depending upon it is important to understand that what sensitization occurs with age. So it is known that from the same article that food sensitization reduces with increasing age, and aeroallergen sensitization increases with the increasing age. It has been shown over here, aeroallergens includes the house dust mite, the animal danders, the moles, and various pollen grains, which actually increases with the increasing age. So this has to be kept in mind while we are evaluating a particular patient. Then we come to the actual patient's symptoms with which the patient has come to us. Okay, patient usually come to us with a particular set of symptoms with which we diagnose a disease, and then we go about in understanding that what is causing the symptoms in these patients. So the symptoms can be pertaining to the respiratory tract, the symptoms can be pertaining to the eyes, the skin, the GI tract. And depending upon what symptoms the patient has come with, we diagnose patients to be having either allergic rhinitis or allergic asthma, or atopic dermatitis, or allergic rhinoconjunctivitis, or maybe a combination of one or the other, which could include a rhinitis with an asthma, rhinitis with a chronic rhinosinusitis with nasal polyps, and rhinitis with the food allergies, which it is very common to have the combination of these diseases together in a particular patient at a particular time. So this helps us as in delineating that in what we should focus at that particular time. Obviously, if it is a nasopharyngeal allergy, we would focus on the aeroallergens. If it is some sort of food allergies, we think obviously food allergens, and likewise we have to go accordingly. So then very, very important to understand is the seasonality of the symptoms. Every patient should be asked these questions: that when do you suffer from the allergic symptoms? Do they occur in only a particular specific months, or patient get the symptoms all year long, and maybe all year long with certain seasonal exacerbations? And we have to jot down the months of the exacerbations, because by that way we can help to actually pinpoint the allergens. It is known by and large that the dust mite, usually the patient will have perennial indoor symptoms, and perennial symptoms mostly when they're indoors, and with some seasonal increases. Pollens is obviously, for the seasonal pollens, is a seasonal symptoms, mostly when the patient are outdoors. Cockroach allergen is a perennial symptoms. Moles, for outdoor moles, is seasonal. Indoor moles usually have the perennial symptoms of rhinitis or an asthma. And pets, perennial symptoms, but there can be intermittent exposure when somebody visits a house where there is a pet. So this leads on to the use of the pollen calendars. We have known that it's already known that what is actually a pollination calendar and what is a pollen calendar. Every pollen calendar starts with a pollination calendar because we have to understand the local flora of the particular area from where the patient is coming. Because depending upon the local flora, we understand that which flower, what is the flowering time of the various plants in that area. So depending upon that, we have to know from previous studies done, aerobiological studies, that which are basically the allergy causing flowers. Majority of the flowers do not cause allergy. Only about 2% maximum of them cause an allergy. So we need to know which are the allergy causing flowers. And depending upon that, usually a pollen calendar is actually we need to have a pollen calendar that is as the amount of the pollens in the ambient air of a particular plant and throughout the year how it varies. So it takes a very much a meticulously and it is definitely a big task to develop a pollen calendar for a particular area. We measure the pollens every season for a particular year, and then again we have to do it consecutively for 5 years. And then after that, after 5 years, using some statistical methods, so we smoothen the curve and we then come to the pollen calendar. So these are few of the pollens which are quite common. This is typical how a pollen calendar looks like. And the dark brown areas are the months when these pollens are quite high in the air. So this is how, and then we have to correlate it with the patient's history or the exacerbations if there is a definite seasonality of the symptoms in that particular patient. So for moles also, the mole spores are sporulates in a particular time, and depending on that, we incorporate it in the history, and from that we just have to find out that which moles to be included in the allergy testing. As you can see that the Aspergillus fumigatus, it's mostly in the rainy season, and this Cladosporium, it's mostly in the winter, and there's Carvularia again in the rainy season. So this is how we just correlate that when you're getting maximum of the symptoms, which are the worst months for a particular patient, and depending on that, we go on selecting about a particular pollens or spores to be included in the testing kit. Then comes a very important is how is the control of the disease? The control of the disease, we know that whether the allergic rhinitis is an intermittent thing or a perennial thing, and then mild or a moderate persistent. Similarly, for an asthma, now we have about GINA level of controls. Very important to have the control, because if the disease is poorly controlled, usually in those patients we do not embark doing a prick test, because that may exacerbate the patient's symptoms. And at the time of, and also we in the control questionnaires, typically we in asthma, we know that we ask them in the past 1 month whether you are having like how many exacerbations in a week, in needing a short-acting beta agonists in a week, then whether it's affecting your activities and whether it's affecting your sleep. And similarly, we just say whether it's a controlled, partly controlled, or uncontrolled asthma. And with all this, we help to understand whether we are dealing with an allergic rhinitis primarily, or an allergic asthma, or a combination of the both. And this helps us to initiate an appropriate pharmacotherapy for the patient, and also to understand what is the allergenicity, so that we can evaluate the patient accordingly, depending upon the patient's seasonality or symptoms, patient's and the patient system which is involved. Then this is the location of the occurrence of the symptoms, and the association and to the time of the day is also very important, as I have said, whether it's in whether the patients are worse during the weekends or on the work days or in the school or at home, and when the symptoms are worse, whether it's at night, in the morning, in the afternoon, all day long. And this helps us to understand that when the exposure is more and whether it can be correlated with the patient's history. And this helps us to understand how the disease control is over an entire day. So at the same time as the asthma, we can take the help of measuring the peak expiratory flow rate, and we can see the diagonal variations, which helps us to understand that when the variability, whether it's more during the weekends or if it is more during the work days and the school days. So in this way, it's again help us to understand the same thing, whether we are dealing with the dust mite, which is mainly causing the symptoms in the patients, or pollens, or the cockroach molds, or the pests. Then what are the precipitating factors? This is a very important questions we need to address in the patient's history, taking that what the patient thinks is precipitating the symptoms. Patient gives the clue. The patient gives the history, and it's an intelligent patient actually makes the life easier for all of us. So, and usually the patient will come whether the patient were going to bed or when the patient is walking in a garden, or like the patient is doing some activity and things like that. Maybe the patient is eating something and that is causing the symptoms. So this helps in identifying the source of the allergen exposure. Or it could be an irritant, like anyone who goes to a dusty environment or dusting will get some symptoms of the sneezing, rhinorrhea, and things like that. So it does not mean that it is an allergy, or maybe in a highly polluted time when the air quality index is poor, particulate matters are high, then usually one gets more frequently the symptoms of an asthma or the rhinitis. So therefore, this helps us in delineating appropriate avoidance measures, which we need to discuss with the patients and after taking the history and after doing the specific test. Past history helps us to identify that how the patient has progressed on the atopic march or the allergic march. So this past history also helps us to understand whether the patients had any specific triggers in the past, which could be some drugs, which could be some vaccines, or which could be some food, or how the thing started. And we understand quite well, because allergy is not a one time, it's not a disease. What we're seeing, the patient is in a cross section, but it is actually a disease which starts very early in life, or maybe in utero, and then it progresses throughout the life and involving one or the other systems. So to halt the progression, we need to understand the progression well in a particular patient, and this helps us in deducing the same treatment plan for the patient. This is the atopic march. We all have seen this. We all know this. Usually in the early years, we have the atopic dermatitis or the eczema and the food allergies, and which goes on to the allergic rhinitis and the asthma, which is more in the later years, like after the 3 years or the 4 years, then it is more, or maybe in the adolescence period, where the nasobronchial allergy is more common. Family history is important to understand whether how predisposed the patient is. We usually know that allergy runs in the families. So if there is no close relative, then incidence is around 12%. Both the parents suffer from allergies, 30-50%. If both the parents have allergies and the same kind of the system involvement, it goes up to 50-80%. So all this helps in increasing the pre-test probability of having a particular allergic disease, and so that we can, when a test result comes, to infer the result, we have more points. We actually gather the points which increase the pre-test probability of having a disease. Then after the test, when the result comes, we discuss the result in the light of the pre-test probability, and we come to an inference. So that is how we go about. So always it's better to take a family history, which is important. Medication history is important to understand what medication the patient was on, and how compliant the patient was and how much the medication helped in controlling the symptoms. And if the patient has any antihistamines, is on an antihistamines or any other medications which can actually which can definitely, which can, if you're doing a skin prick test, alter the results, we have to stop those medications. So this helps in reducing the pharmacotherapy for the particular patient and also for giving specific advices before a skin prick test if the patient is on certain medications, which is going to actually reduce or make the results negative. So that's why it's important to understand the current medications and appropriateness of the medications. Then we'll then know whether how much we need to up titrate or the down titrate, how much drugs we need to add, and what drugs we need to stop before a skin prick test. So this was a very interesting article which showed that allergic respiratory diseases, different allergens and different symptoms. They said the seasonal allergens were more associated with the rhinitis, where perennial allergens were more associated with an asthma. So, but we can see there's considerable overlap between all these, but still means this is important. So depending upon the entire history that we have taken, this is based on the history of the patient disease and the environment, we select the allergens. So how do we select a short, relevant allergen panel? I'm not talking about the food allergy today because it's mainly respiratory allergy that we're concentrating. We did not do everything. We need to have a short, relevant allergen, maximum 10 or 12 allergens, maybe. So we know that from community reference on Indian literature and personal communications with the clinicians, we find that house dust mite is a major allergen, constitutes 50% of the allergies most of patients. Pollen grains constitute 20 to 25%, smalls 7 to 10%, insects 10 to 20%, and animal land around 10%. So we need to have this in mind while we are actually planning and relevant allergen panel. So selecting a dust mite, we mainly take the Dermatophagus stauronosinus or the Ferini. We may add Bromea tropicalis, as because few of the study shows its increased sensitization rates. But if we are doing only with Dermatophagus stauronosinus and Ferini, also this suffices, because we published the study in 2018. We showed that the Dermatophagus Ferini and stauronosinus sensitization were as high as more than 80%. And so this is important. And various other studies done from various other parts of the India also showed the high prevalence of the TF and the TP sensitizations. And the results were similar. So that is how we can have to choose these two dust mite allergens while we are testing for the dust mite allergies. For the pollens is mainly three groups: the grass, weed, and tree. And we have to remember there's lots of cross-reactivity between the pollens of the various groups, because there are some proteins which are quite ubiquitous in the plant kingdom, like the non-specific lipid transfer proteins, the polcalcins, and similar other proteins which are quite common. They're present in all the plants of the plant kingdom. So maybe if we are having an sensitization to one of those, there would be lots of cross-reactivity, and all those will come out to be positive. Well, this we cannot delineate it while doing specific IgE or a skin prick test. And for this, as the newer molecular diagnostic tests helps handy. But majority of the time, when we're correlating with the history, then we get the best results. Then we do not have to embark on the expensive tests, because again, that is when correlated with the history, then the panel decided, then the post-test as correlation is done, we come to fairly a good clinical decision on which we can and actually build up our treatment for the particular patient. So again, the grass pollen is mostly common. So it's all the Puidae family, it's a genus. So if we are taking Propoaceae, so if we are taking whether it's a grass pollen mixture, it is common for whether it's a Puidae, Chloridoideae, or the Panicoideae. For the weed pollen, depending upon different areas, from different locales, whether southern India or eastern or western or the northern Indias, we have a majority of which are the pollens important in which areas. We have a good guidelines for that, and we can definitely follow those guidelines to determine the pollens. For the tree pollens, again, it is a major tree pollens of the different areas in our country has been well delineated by very good aerobiological studies. As moles, so these are the few moles which are common, depending upon that when the patient is having more symptoms and when the patient symptoms are more, we say that due to alternaria, aspergillus, cladosporium, and this rhizopus. So usually this suffices for the majority of the moles that we can say. Insect allergies, definitely the cockroach, whether it's an American or the German, there's lots of cross-reactivity between the two. So, and that has to be included if the patient has perennial indoor symptoms and if the patient is suffering from the asthma. Animal epithelia, depending upon what is the patient in the patient's household, we choose the particular animal dandruff. It is important to understand one very important point, that the house dust extracts be considered ineffective, unsafe, and misbranded. So it should not be house dust. It has to be a specific house dust mite, whether it is a Dermatophagoides sternonicinus, Dermatophagoides perini, Blomia tropicalis. So any commercial extract, if it's only house dust, it is advised not to use that because that is not safe and the patient can land up into having anaphylactic reactions. And so it is a mixture of the various dust mites. Always we have to be as much specific as possible, and that is important. And so the cotton dust we should not include, is not an IgE mediated disease. So such non-relevant allergen extract should not be used. So by and large, by the history, proper history, selecting the allergen panel properly, and also after the test result comes, again correlating with the patient's history, we've come to a fairly good allergy diagnosis for the majority of the patients, hence in our clinical practice. And on that only we have to build up our treatment. It should not be like a run-of-the-mill testing we are doing, and we are clueless about what we have to do with the results. Patients is also confused, and by that way we bring a bad name to a specialty. It should not be done. It should be done only in the correct scientific way in which I have just delineated. Thank you so much. So yes, so now we have a very interesting panel discussion, and for the panel, this panel discussion would be moderated by Dr. Mahesh. I think all the questions that we'll have, we can address it in the end. And so I would like to invite Dr. Mahesh, and I'm privileged to invite him. Dr. Mahesh is a professor of respiratory medicine at JSS Medical College, Mysuru. He is listed in Stanford University World Top 2% of Scientists in 2021 and 2022. And we all basked in his achievements. And so he being a clinician and a scientist, so from our fraternity, from our country. Ranked first in the world ADG rankings for the highest citations in the last 5 years. And his total citations is a whopping number of more than 90,000. Publications of 310. His H index is 65. He served in 9 committees of the American Academy of Allergy-Asthma and Immunology. He is also the guidelines committee member for biologics in asthma in the ACCP, and also guidelines committee co-chair in the pharmacotherapy of asthma therapeutic overlap for the American College of JSS Physicians. So good evening, Dr. Mahesh, and I would like to request you to moderate the session and welcome the panelists for the panel discussion.
Yeah. Thank you, Saibal, for the kind introduction, and good evening to all of you. At the outset, I would like to thank Indian Society for having given me an opportunity to moderate the panel discussion. We have a very eminent panel with the well proven track record in managing allergies and asthma. And we have with us a very senior member, Dr. Nagendra Prasad. He is an allergy practitioner since 1980 at Bangalore. He is a member of IACI as well as the QADAI and WAO and ERS as well as the Indian College, in which he is in charge of the South Zone. He has a patent possession on the slit, the stripe, and his patent pending on the HTM slit tablets. And he's been working on dispensing personalized probiotics to enhance tolerance among allergy-prone subjects. This is Dr. Nagendra Prasad from Bangalore. Dr. DJ Christopher needs no introduction. He is very well known among the Indian Society. He was the past president. He is currently the professor in the Department of Pulmonary Medicine in Christian Medical College, Vellore. In South India, he is the chair of the Scientific Advisory Committee in the ICMR National Institute for Research in TB. And he is the chair of the research committee of the ICS. He is the course director for MACOR, that is from the American Thoracic Society India program. He is also the course director for the Diploma and Allergy-Asthma DAA program in CMC Vellore that is running successfully for the last more than 15 years. He is a member of the R&D Clinical Characterization and Management Research Expert Group from the World Health Organization from June 2020 onwards. He has over 300 presentations in various national, international, as well as regional forum. He has about 16 book chapters. He has 235 published original articles. And he is listed in the Stanford University World Top 2% of the scientists in 2021 and again in 2022. He has won the Grand Challenge Award in 2012. He has occupied the Ida Scudder Endowed Research Chair in CMC Vellore, and he has delivered 7 orations. And then we have Dr. Jaffrey from Indore. He is a pulmonologist as well as an allergist. He has a proficiency certificate from the Maryland University, USA. He has done his fellowship from Munster University in Germany. And he has experience of over 32 years. He does a lot of work on allergy testing, immunotherapy, various, and now he's also started CRD. He's a life member of various organizations such as Indian Chest Society, ICAI, Indian Critical Care Society, National College of Chest Physicians, ERS, WAO, ATS, as well as the QADAI. And then we have with us Dr. Pramod, and he has completed his MD in pulmonary medicine. He's a consultant pulmonologist and a sleep and critical care specialist at Mittal Hospital, Ajmer for the last 18 years. He's also trained in sleep disorders from Sydney, Australia. He has done interventional pulmonology training from France. And he took his training in allergy in IGIB and VP Chest in 2005. And then in Ajmer, he's been doing all the allergy testing and as well as immunotherapy. He started the first respiratory sleep center in Ajmer in 2005. He has about 15 publications and has received the KC Mathur Award. His main areas of interest, of course, are asthma, allergy, COPD, infectious diseases, critical diseases, and sleep disordered breathing. He's been regularly involved in various CMEs, workshops, and seminars and webinars, and as well as the social work as well. And now with this, we have a very eminent panelist today, and we will start with the case discussion, and then I will request the panelists to contribute. Can I request Ankita or Soma to allow me to share the screen?
Yes, sir, you can share the screen, sir.
Okay. Is it visible?
Yes.
Okay.
Yes, sir, yes.
Thank you. So we'll just start with the brief case history. We have Mrs. Yes, who are suffering from recurrent attacks of asthma. since the last 15 years. In the first year, she had only 2 attacks, which resolved immediately after oral medications. Her frequency and severity of attacks progressively worsened. So this is a very important piece of the history. When somebody is suffering from various allergies, you will find that disease tends to progress in 80% of the time. When we say progression, you have to collect history on how has the disease behaved in the first year and how it has behaved in the last year. Is there increase in frequency, increase in severity, increase in medicine requirement, increase in disturbance of sleep and daily activities, involvement of the other organs, and the time of each of these attacks. So these are important points to be collected if you're looking at progression, disease progression. And she needed hospitalization at least twice a year in the last 5 years, in spite of following GINA guideline-based treatment as well as assessments. Now she has perennial symptoms even with treatment. Her FE1 is 60% predicted when she is stable. FeNO is 50 in spite of step 5 treatment. She is not used any biologicals as she cannot afford it. I would like to request DJ to please give his thoughts on this case and what are the points in the history that could be of relevance in this case. What are the possible differential diagnoses that one should consider? Can I request DJ Christopher to...
Thank you, Mahesh. Thank you for the introduction. And I am very pleased to be invited by the ICS to be part of this panel. Mahesh, I was listening to the case. I think you've chosen a very good case. This is a typical case where asthma control has deteriorated over a long time, over years. So we're looking at the patient with that perspective. I would start with a thorough history. I would require from the patient details about precipitating factors such as exposure to dust, pets, and other environmental agents that worsen symptoms. I would also probe about seasonal variation. Are the symptoms constant through the year? Which are the times in the year that things get worse? Take a occupational history of smoking. I mean, if she's a lady in our country, most likely she's not a smoker, but that's a history that we need to take. So I would start there. All these have bearings on control, and I would start there. Then I would look at, you said that she has been on GINA guided treatment. Now, that doesn't assure us that everything has been done perfectly and the patient has had the right medication the right way. I would start by looking at all the drugs the patient has had, in particular the inhaled drugs, and ensure that the patient has taken the right drugs. And I would look at how many times she has received oral corticosteroids. That obviously reflects poor control, and that information is important. And it also has bearing on other side effects and comorbidities. She has had exacerbations that require admission. So I would want to know how bad were these exacerbations, how was she treated. In all likelihood, she would have had nebulized bronchodilators. Did she require oxygen? That may indicate that the asthma was much worse than just having nebulization with normal saturations. Now, if the patient was ventilated, that is a very catastrophic event, and this could have bearings for future care. Ensuring that she has been compliant. Now, compliance is a crucial issue. We look at prescription and think that patients are taking them, but it is very important to ensure that she's been compliant. It is very important to ensure that she has good inhaler technique. So all this I will check with the understanding that she is a case of difficult to treat asthma. But we need to go through all this to see what are the factors that we can change. And of course, last on the list of things I would like to check are comorbidities. Top on the list for me is the respiratory allergy comorbidity, allergic rhinitis. I would like to know whether there's postnasal drip along with it. I would like to know if she's got gastroesophageal reflux, if she's obese. So I would like to go through the list of comorbidities, and then I think we are ready to move forwards. Thank you.
Yeah, thank you, DJ. And would any of the other panelists would like to add any other information, possible differential diagnosis? Yes. Dr. Nagendra Prasad, please.
Yes. I would like to know the age of the patient and the occupation of the patient. And we should know about the atopic history, which is allergic in nature. And BMI, which is already mentioned, there's one of the things. And a phenotype, the asthmatic conditions, so that we can distinguish from allergic to the non-allergic and other factors. And most of the points which is covered by the Christopher, I support him. And the place of living and any history with the change of places, does the symptoms correlate? And is it more in the daytime or afternoon or in the night? These are the history which is more relevant for allergic in nature.
Absolutely, all good points. And thank you, DJ and Dr. Nagendra Prasad. We'll now move on into the details of the case. These are some of the points that could be collected. These have all been mentioned, that what are the points to be collected. Critical is, though they are perennial, the worst in December, January. There is also allergic rhinitis that Dr. DJ talked about. She also has a mild itching of the eyes. There is a farmhouse where she spends a couple of days a week, but the symptoms are the same whether she's in the city or farmhouse. She's also exposed, very, very important to ask. This is Dr. Sandeep Salvi has done a lot of work on this. And there are hidden allergens or the hidden worsening agents, such as new paint, for example, using of mosquito coils, using of incense sticks or doop sticks. You can light diyas as much as you want, but the incense sticks and doop sticks are equal to smoking. And they can cause an eosinophilic inflammation to turn into at least initially, a temporarily neutrophilic inflammation, which makes it very difficult to control. Again, Dr. DJ has brought about BMI, which is 32, and absolutely there is symptoms of GERD. With that, we will go in. And again, I would like to invite Dr. DJ Christopher here as to what are the possible investigations that could be needed and what could be the rationale and the comparative strengths and weaknesses. Dr. Christopher.
It is clear at this point that this patient needs to be investigated. So I would start with basic tests. I would do total differential counts. I would like to know the eosinophil counts. If required, work out absolute eosinophil counts to see if a high eosinophil count is significantly high. I would do a chest X-ray. Someone with chronic symptoms could be suffering from other conditions that mimic asthma. We once had a patient that was managed for asthma for 8 to 9 years, very similar to this patient, never got significantly better, treated by several practitioners with almost all the asthma drugs in the market. She eventually had a tracheal tumor, which was missed. It was a benign tumor, but occluding 90% of the trachea. So I would want imaging done. And then you say she has allergic rhinitis, but anyone with chronic asthma, as part of workup, I do a sinus X-ray at least to see if there is a sinusitis. Many people say everything is fine, but you see significant sinusitis, which may be impacting the asthma control. Of course, I would do allergen skin testing and try to confirm as much of the history that has given clues to what she may be allergic to and make correlations. I would do spirometry from 2 points of view. First is to confirm now if she has a reversible airways obstruction. Secondly, she's had chronic symptoms, and in all likelihood, she would have a fair amount of fixed airways obstruction. So I would want to check that out. Then, in terms of assessing inflammation, what is non-invasive that is now freely available is FeNO. I'd like to check her FeNO levels and see if that indicates inflammation. And finally, not routinely, but in cases like this, to complete the workup, I do an IgE. So we do not want to miss ABPA. So fungal sensitization and skin test and IgE are good pointers to more advanced tests to confirm ABPA. So this would be the first rung of tests I would do, Mahesh.
Absolutely, DJ. Yeah. Thank you very much. And any other points anybody want to say? Dr. Jaffrey, Dr. Pramod?
Dr. Christopher has almost taken everything. I think everything is perfectly fine. Only thing is, suppose there is no reversibility and chest X-ray shows some kind of a shadows which needs to be confirmed, then only in that case CT chest would be advisable. Otherwise, I think eosinophilic inflammation, IgE, FeNO, everything has been taken care, reversibility and everything. So I think Dr. Christopher has really summarized very well, and the rest of the colleagues, if they can contribute something.
All right, we'll move into
Mahesh, if nobody has more to say, I just wanted to reiterate something that may be of interest to the people watching this program.
Okay.
So in the last couple of years, the ATS and ERS have, they have come out with their guidelines for lung function testing. And a notable change is the definition of reversibility. It used to be rule of thumb for us, and we all knew this by heart, that reversibility is 12% and 200 ml increase in FEV1. That was the rule of thumb formula for reversibility. And we used to calculate reversibility based on post-bronchodilator minus pre-bronchodilator divided by pre-bronchodilator. This has changed. So reversibility is now calculated as post-bronchodilator minus pre-bronchodilator divided by the predicted FEV1, not the actual FEV1. The reason being that if someone has very low FEV1, for example, 1 liter FEV1, a 12% increase is so small. But from the definition point of view, that will appear significant. So now the definition is an increase of 10%, but it is based on the predicted FEV1 and not based on the pre-bronchodilator FEV1.
Oh, fantastic, DJ. I think those are very important points, especially for the postgraduates. And now we will go into the investigations. Lung functions, we have already said in the first slide, is around 60%. Skin prick testing was done, and these are the results. Now, Parthenium and Artemisia both are weeds. It's about 25 and 17. Prosopis is a tree. It's about 14. Haustus mite is about 5. Histamine is 5 and control is negative. Now, can I request Pramod to share his thoughts on to the skin prick test results? All the rest are negative. And what other tests could be relevant? Is there a role for total IgE? Is there a role for AEC? Is there a role for specific IgE? And how to attribute clinical relevance to these test reports? Dr. Pramod?
Yes, sir. So considering the history of the patient and the skin prick test results, which are shown. So as far as the reports of the skin prick test is considered, they are showing the positivity towards pollens also and towards the house dust mite also. But as far the history is considered, the symptoms are more in the morning hours, and they are suggesting towards the possibility of allergic towards the house dust mite. Regarding the pollens, if you can see that the Parthenium, Artemisia, and Prosopis, they have the different seasonal peaks. The Parthenium is more prevalent in the 2 seasons, in the February to March, and then again July to August. Similarly, Prosopis have a different season, Artemisia have different season. So, and the history also, when she was going in the farmhouse, there is no difference in the symptoms. So as far as the correlation of the skin prick testing report with the patient history, they are not matching. So what I personally feel that as for the history of the patient, house dust mite is the main culprit, which is probably responsible for more symptom worsening in the morning hours. As Dr. Christopher already discussed about the importance of total IgE, definitely IgE is an important role to play. And a specific IgE, if you talk about, especially for those allergens, is very important in this case. Then talking about the AEC also, it has also an important role to play, because once you will see the pathology of allergy, whenever the allergen invades the body, it is going through the through different parts, and the release of interleukin 4 and interleukin 5, which is responsible for the activation of basophils and then eosinophils, and finally leading to the cascade of events. So if talking about the value of AEC, total IgE, specific IgE for the allergens, is very important in this case. And as far the history is considered, so it is indicating towards the possibility of house dust mite, which is responsible for the worsening of symptoms. This is what I feel, and
yes, absolutely, yeah. Thank you, Pramod. That's a very nice interpretation. So it's very important that after each test, for every patient, you have to take a history again based on what are the positive results. Now, as Dr. Pramod rightly said, for an early morning symptom, the most likely relevant allergen is house dust mite. She has maximum symptoms during December. Again, it's most likely relevant is the house dust mite. She has no additional symptoms when going to the farmhouse, when she's supervising, DVDing in her farm for several hours. Also, she has no extra symptoms, which means that she is only sensitized to Parthenium and Artemisia, which is not clinically relevant. Now, in February to April, that's the peak season for Prosopis. When she goes outdoors, she has only mild eye itching, but cough or wheezing doesn't get worse. So Prosopis is of mild clinical significance for her, only for her allergic conjunctivitis, but not her asthma. So Dr. Pramod has rightly interpreted that, this is the clinical interpretation of the test. The size doesn't matter. The value of the skin prick test or the specific IgE should be correlated with the history, and then only you will be able to understand the clinical relevance of this particular test. Does anybody else want to add?
Yes. Yes. See, there are two things which are perennial in our history. One is ambrosia, that is Parthenium, and second is dust mite. And she has a early morning exacerbations. Even the pollens have a higher exacerbation in the morning hours, because the concentration of pollen is high in early morning time. So to differentiate this, I think a specific IgE would be very much helpful to differentiate and finalize that the sensitization is much more to dust mite or to Parthenium. Because in SPD, sensitization is much more to Parthenium in compared to dust mite, although history is favoring dust mite. So I think if we do a specific IgE, this is a nice case to do a specific IgE.
All right, thank you, Dr. Jaffrey. Anybody else? Dr. Nagendra Prasad, Dr.
So one step ahead, we can think of CRD, component result diagnosis, which is available right now, and which may give a correlation between the food as well as the pollen sensitivity, because she is suffering from pollen sensitivity, and we can correlate the test parameters the history and the events, which is not very coordinating. That means you could not able to give a consolidated focus on the treatment. It is a variable. So I think one has to take a very clear history. History supporting to these diagnostic parameters may help in giving a appropriate treatment.
So now to move on, of course, if you look at additional symptoms, Mrs. S also complained of an oral itching and swelling on eating cabbages and cauliflower within 15 minutes. There were no systemic symptoms, but they responded to antihistamines. Now, what is the term that we use to describe this clinical condition? We hear a lot of our patients say grapes or oranges. They have so many foods that they say as soon as I eat it, I have itching or swelling in the mouth. So it's a very, very common history among patients with allergic rhinitis and asthma. So what would you look for in this patient? How would you confirm the diagnosis? Are there any advanced tests now in India that could help? I would like to request Dr. Jaffrey to comment on this.
Thank you so much, Dr. Mahesh. This is a very common thing and it's called oral allergy syndrome, often also called pollen food syndrome as well. So basically it is because of the cross reactivity of certain proteins in the pollens and the food. And that's the reason certain foods actually causes symptoms and patient feels like that he's allergic to that particular food. Nowadays, we are lucky to have a component resolved diagnosis in India is available, and that is very good tool to differentiate the exact allergen and the cross reactivity. And there are certain proteins like procalcinin, PR10, LTPs, lipocalcin, profilin. These are the things which actually cross react, and we have heard about Birch apple syndrome and mugwort mustard syndrome. Like these things are they happen because of the cross reactivity, and actually this is the right place to do CRD, and we can really properly differentiate and do a proper diagnosis. Thank you.
Yeah, thank you, Dr. Jaffrey. Dr. Nagendra Prasad, you would like to add?
The component resolved diagnosis is available in the market, which may be a good tool, but most of the pollens, what is found in India, which is not reflected in this particular kits. So it is very difficult. Probably we had to think of like the Parthenium and ragweed like this. The logic founds here, but not in reality. It is too early to adopt the CRD right now, until unless we get an entire range of pollens which can be covered under CRD. That may be helpful in the long run. Go to Mahesh.
Yeah. Dr. DJ Christopher, Dr. Pramod, you want to comment on the CRD?
So it is a big problem as far as our country is considered, because in North India, some pollens are totally different. They have different seasonal timings. In South, you will go to different pollens. So as far as CRD is considered, the kit is not, whether it is standardized, whether it is reliable or not, it's a very big challenge for a clinician to understand that. But still, it is a good tool, at least for these type of combined allergen which are responsible for producing the symptoms, especially these pollens and the food when they are intermingling with each other and symptoms are produced. Then definitely it will be helpful to S2 to the conclusion.
Absolutely. So the key message is that though CRD is very good, we don't have the current portfolio cover all the pollens in India. And she was found to be sensitive to this Artemisia, and Artemisia has a lot of cross reactivity. For example, you have the mugwort celery spice syndrome. You can see all the different, including mango. You will find that this pollen is cross reacting. Mugwort mustard syndrome, again, you see starting from peanut to almond to the cauliflower and cabbages, also to fruits, even to the chamomile that is used in the tea. And then, of course, for ragweed, you have the melon-banana association. So there are several pollens that cross reactivity with the whole group of foods. And when it is available, it can be used. Of course, a lot of work needs to be done for the Indian pollens, but it would be very interesting in the future when we can have this for the Indian pollens at a much lower cost. I think it could be it has a potential to be a valuable tool. And again, as Dr. Jaffrey said, it depends on the type of the common proteins. For example, you have the profilin, you have the PR10, and you have the LTP. So these are the most common, and these are responsible for the various syndrome. And these are the whole variety of foods. And each of these will tell you which food has which of these, and to which of these they are cross-reacting. So it is very, very important that you take a good history. And when patients do say, even your skin testing may or may not show, because these are basically some of these proteins and the extracts that we have. We don't know the actual concentration of these proteins in that extract, but when the patient eats the fresh food, they may definitely have the symptoms. So it's important to note that in the history as well. Now, we know that the patient is taking the best possible treatment. Patient has been adherent to the treatment. Patient is using the spacer appropriately. She's on stepwise treatment except biologicals. Now we want to know what extra can be done for this patient that is more economical, equally or more effective. So I would like to call Dr. Nagendra Prasad to discuss some of these possibilities, and then we will have the other panelists share their thoughts. Dr. Nagendra Prasad.
At the onset, I thank the ICS organizers to give me this opportunity to be a part of this symposium. And the task on this particular patient, which is already in the management of step 5, is very, very, very difficult. Our main task is to bring it to the step 4, step 3, step 2. Then we can think of giving a long-term management, as the GINA guidelines has given additional the sort of recommendations as needed. So the possibilities which we can think of, but may not be applicable to this particular patient. And though the patient has shown some positives to the pollens, and which we have discussed with our friends about the significance of the pollen and the house dust mite. And even if you consider as a significant pollen or a mite, you can't treat because she's already in the step 5. And step 5 means she will be in the heavy, high dose of the steroids, either parenteral or oral, and immune activity is sluggish, and we can't activate the immune system at this juncture. And only alternative what is available in the present condition is the biologicals. And there are certain biologicals which are available in India are really effective for this particular patient, but she can't afford to do it because of economical situation. So the only pharmacotherapy drug has to be given. The more of inhalers, ultralama has to be adjusted, and a mucolytics and a bronchodilators, and taking care of the hydration. So these are the parameters which coming into the fact, whether if it's in the ICU, the different dosages has to be given. And if it's already discharged and working in the home, and she may be required with a higher oral doses. And the inhalers definitely do help and definitely bring them back to the normalcy. And education is very, very important in these patients and may help to bring down the symptoms. And there are some alternative and or economical and equally or more effective management. Right now, we don't have much available alternatives except that inhalers, steroid-based, and ultralama, and also with a LABA. These are the molecules which is likely to help in combination and permutations. And added to that, we have bacterial lysates are available, and these bacterial lysates do help these patients in bringing down the index of inflammation due to the bacterial infection which may be resistant or may be used with a lot of antibiotics, which may be not effective. So now just for this platform allowed to discuss about the immunotherapy. Immunotherapy coming to this patient is very, very difficult. There are few reviews have been published recently. A role of immunotherapy in a advanced, persistent, allergic asthma. So there are only 1 or 2 cases out of 10 cases, they are successful. So I don't think at this juncture we can think of about the immunotherapy to this case. But one should know about what is immunotherapy is. The immunotherapy is the repeated administration of the allergen extracts, which they are sensitive to allergic individuals, in order to provide a long-term relief of symptoms and a quality of life on exposure to the allergens. It is effective in IgE-mediated and is indicated in allergic rhinoconjunctivitis and allergic asthma. Now it has been approved for atopic dermatitis. And this is not a competitive with the conventional use of pharmacotherapy or biologicals. Because the mechanism of action with immunotherapy is quite different from pharmacotherapy and biologicals. Biologicals are always passive immunotherapy, whereas allergic immunotherapy is a very active immunotherapy, and a sustained effect will be there on the long term, even if you withdraw the immunotherapy. But biologicals, once you give it for a short time or a long time, and once you withdraw, the recurrences may happen, like omalizumab. Once you reduce the omalizumab or you stop the omalizumab, IgE definitely rises over a period of time. And we have different types of immunotherapy, which is familiarly known as subcutaneous immunotherapy, which is an injection form. And subsequently, we had a sublingual immunotherapy. We call it as SLECT. SCIT should always be administered by a trained person and assessed to the adrenaline and other resuscitated measures due to the adverse events. That means the SCIT always given by a trained physician rather than given by the layman. Because once the adverse events happens, you should manage how to retrieve. And we have come across with the efficacy of this immunotherapy, which is already, we have crossed more than 110 years of its existence. But the mechanism of action was understood only after once we identify the IgE has been identified of late of 1984. And we have understood much more on mechanism of action of immunotherapy in the recent time with a molecular biology, which is advancing in very, very, very fast. That's why we could able to have a strong hold on the immunotherapy. And when we started in immunotherapy in the 1880s and 90s, we are very, very not able to speak of any mechanisms, but we were giving the results, and results alone was not sufficient to convince the medical colleagues. They used to say it is a placebo therapy, but still we continued and survived. And I'm thanking to the science advancements, which made me to live and continue my practice in allergy because of molecular advancements. And we have alternative routes, which I said, a sublingual immunotherapy. The sublingual immunotherapy has been given in place of subcutaneous immunotherapy. The subcutaneous immunotherapy always do induce a trauma to the patient. He definitely accepts in the beginning, and when we start continuing, and before the completing the build-up phase, and he is already tired because of the pain at the site of injection and the agony which he is getting, and reaching a doctor and waiting in a doctor room and going back, and hardly he could able to continue the immunotherapy in the build-up phase. And once they come to the maintenance phase, and only few percentage, maybe about 30 to 40% of the patients continue with the maintenance phase, and that is one dose in a month. And even that also had some adverse events like anaphylaxis on the 4th or 5th dose, and it was unpleasant to the patients. Then we introduced the sublingual immunotherapy, and globally it has been well accepted. And we had a white paper on this sublingual immunotherapy in 2009 and 2010 by WHO and IACI, and which is not known to the Indian population. And we tried in India at Bangalore, and we could able to successful. The reason why it was introduced, we had a number of software engineers, and they refused to come to the clinic for continuation of the treatment. And that adamant rejection, which made me to penetrate into the slit, and slit was not able to generate. I had one patient with a parthenum at that time. Parthenum was in the top sensitized allergen in Bangalore, and I could able to generate with a lot of literature, and we could able to do it. And subsequently, we found that immunotherapy is very, very effective, and the efficacy on the immunotherapy was shown on a regular randomized controlled studies. And a systematic review on the SCIT is highly effective in allergic rhinitis in the patient with perennial allergy and sensitivity to house dust mites, and marked reduction in requirement of anti-allergic medication during the pollen season. We had one case study, a systemic review, and it is a controlled study, and 410 patients with a grass pollen allergy showed 30% decrease in seasonal symptoms and 44% reduction in need of the anti-allergy medication. And SCIT is effective in allergic asthma, no doubt. A Cochrane review demonstrated significant improvements in symptoms, reduction in rescue medication, and improvements in allergy-specific bronchial hyperresponsiveness. And coming out of the safety, a limitation of this kit is a risk of potential side effects, which I have discussed. And there was a article which has been reported from the United Kingdom about 26 fatalities over 30 years, and similarly about 26 cases in 15 years from USA. So the indication of immunotherapy is the IG-mediated disease, which is showing a positive to the skin prick test, and also the specific IG. And patients who are not able to avoid the allergens and inadequate of drug treatment, then this is the only treatment is available. The contraindications: coexistent uncontrolled asthma, patients taking beta blockers, patients with other medical immunological disease, a small children less than 5 years for SCIT, and now less than 3 years is not permitted in this for SCIT. And a pregnancy, of course, maintenance injections may be continued during pregnancy. Coming out of the sublingual immunotherapy, a Cochrane systemic review and a meta-analysis of 60 studies, of which 49 studies out of covering about 4,589 participants were suitable for pooled analysis showed that sublingual immunotherapy was effective for seasonal and perennial rhinitis. So recent well-powered randomized controlled trials on sublingual tablet have provided consistent evidence of efficacy with a decrease in symptoms and rescue medication during season, resulting in registration of 2 sublingual tablets vaccines in USA. And SLIT grass tablet was effective in all nasal and ocular symptoms, and it is treated for 3 years, was shown to have a disease-modifying long-term sublingual immunotherapy in children with a grass pollen rhinitis with a preventive progression from rhinitis to asthma. The preventive allergy treatment study, that is a PAT study, is being addressed in the GAP study. There are 3 large trials of sublingual tablets have performed that induce a total of 4,022 participants with a perennial rhinitis and IgE sensitivity to house dust mites. Tablets were taken daily for 12 months. all three trials show evidence of efficacy in rhinitis with a clear dose response and a 18 to 28% reduction in combined symptoms medication score compared with placebo. A study in adults showed that mild tablet sublingual immunotherapy was able to reduce the requirement of inhaled corticosteroids and frequency of exacerbations in mild allergic patients with moderately severe asthma. Immunotherapy is alone, we can stop the inhalers, but without the immunotherapy, the inhalers cannot be stopped. So safety of the slit was well tolerated. Minor local symptoms of itching, that too happen with build-up phase. But now this build-up phase is not necessary in the slit. We can right away, we can go with the maintenance dose without having adverse events. Now, what are the other routes of immunotherapy which is available? One is which I discussed about sublingual, then the intranasal route. Intranasal route was very successful and they were giving a very good response. But the possibility of inhalation with the nose, they used to suck into the, trickling into the bronchus and likely to cause with a bronchospasm. So that has been discontinued. The oral route and interbronchial route. The oral route also causing a severe abdominal cramps and other side effects. And interbronchial route, the certain patients used to go to the severe bronchial attacks, which was not recommended. Then the epicutaneous route, which is coming up, and application of patches containing allergen directly to the skin surfaces with using a microfiber needles. And the latest is the intralymphatic approach that involves injecting allergens under the ultrasound controlling directly into the lymph nodes in the region of the upper thigh, that is in the inguinal region.
Yeah,
This
thank
is
you, Dr. Nagan. Yeah.
just 1 minute. I'll be 1 minute. Can I have 1 minute?
Yeah. I think we are nearing the end of time. So please quickly wind up.
I will be winding up.
Yeah.
The intralymphatic is showing a very good promising result. And with the 3 doses of a monthly interval, which can have a sustained effect for 5 years to 10 years of the symptom-free period, it is a promising. And I think the number of trials which is coming up, earlier it was only 2 trials was there, now which is already crossed 22. Then future strategies, we have a development of purified recombinant allergens and modified vaccines, and a novel using the novel adjuvants in order delayed absorption and modifying T lymphocytes response are currently under investigation. So this is my submission, and saying that immunotherapy has a bigger role. We thought when the inhalers came into the forefront, we thought that immunotherapy has no role, but still the immunotherapy has a big role. Now we thought biologicals are taking place, but biologicals could not replace the immunotherapy because this is an active immunotherapy, there is a passive immunotherapy. I think immunotherapy has a big role in the future days to come. Over to Dr. Mahesh.
Yeah, thank you, Dr. Nagan Prasad. I think we are now nearing the end of time. We will take the comments from each of the panelists. Dr. Christopher, you want to share your thoughts and final comments?
Mahesh, I think I'll just allude to the first case. I think that was excellent case chosen to depict all the aspects of history taking and investigations that need to be carried out in a patient. And I'm sure it was of use to a lot of people who may have tuned in to watch this session. I just wanted to add just one more point in closing. The value of engaging patients in their care. We do not give enough credit to patients in co-managing their disease with us. We always want to be the people telling, and we want them to be the people listening. So there are numerous studies that have shown that discussion with the patient of the options, a written action plan, giving them flexibility to reduce dose within a range, and teach them to self-monitor their disease. And participating in their care is a very important step. This has been confirmed by numerous, not observational, but randomized control trials. So I just want to reiterate this important aspect of patient management. With that, I close. Thank you.
Thank you. Thank you, Dr. G. And can I now request Dr. Jaffrey for his...
Good evening, Dr. Mahesh. I think most of things has been really taken very well. You chose a very right case, really a case with a lot of gray areas where there a nice discussion has gone. Dr. Christopher, Dr. Nagendra Prasad has really contributed very well into all in-depth analysis. I think there's nothing more to add on to this. So I close here my remarks. Thank you so much. Thank you indeed.
Okay, thank you, Dr. Jaffrey. Now, Dr. Pramod, you want to give any key message?
I'm thankful that I'm part of this panel discussion because you all are very big shots and we have learned many things from all of you. And Dr. Nagendra Prasad he's a man of allergy and he's introduced each and everything about the slit in our country. One thing just I want to share, because I have a very short experience of managing these allergy patients and I'm using slit in many of my patients. What I observed that definitely whether the studies are endorsing just to use slit in allergic rhinitis patients, not in asthma patient. But when any patient of asthma, whether is a case of moderate, severe, labeled as a moderate or severe initially, but over a period of time when you control the symptoms and when you add slit in this group of patient also, definitely it helps in reducing the medicine burden and also helps in improve the symptom score. So I think that in future time, the studies will come where slit will help along with the pharmacotherapy in severe asthmatic patient also, though it is a contraindication presently, but not in acute phase. But once the things are stabilized, then definitely this should be added. The allergen avoidance by the patient and addition of slit and discussion that Dr. Christopher has rightly said that time is required to do the counseling. We are two wheels of a car. We cannot run alone. Our patient should also be with us, and we should give all the options which are available for the proper management of the patient. I'm thankful to ICS to give me this opportunity to be part of this panel discussion.
Yeah, thank you, Dr. Pramod. Now, Dr. Saibal, you want to give any take-home message or key message?
Yeah, thank you. Yeah, everything has been covered so nicely by all. So one thing is very important to understand, that while we are dealing with a case of respiratory allergies, so for that instance, say asthma in this case, so what we are mainly intended to do, our main goal is to control the disease, which will translate into reducing the future exacerbations, at the same time to reduce the steroids in inhaled form or oral form, and to improve the quality of life of the patients. So these are our main goals in the treatment. So when we are dealing with the patients of our country, the biologicals is always an option, but it depends whether the patient can afford it or not. And majority of our patients cannot afford the biologicals, even if they are having a T2 disease like an asthma. So what we are left with, to give them a good quality of life, definitely along with the disease control with the pharmacotherapy. If the disease is triggered by an aeroallergen, say house dust might trigger the disease, not only mere sensitization. And if we can actually show this in the patient by proper testing and proper post-test evaluation, then along with the allergen avoidance and the pharmacotherapy, there always remains a window of giving a immunotherapy, while taking into consideration the risk-benefit ratio. The risk is always there because of the allergen causing an exacerbations of the disease. But if the disease we're able to achieve the control by giving the highest possible pharmacotherapy at this stage, and still we are not able to reduce the dose of the inhaled corticosteroids, if the disease is controlled, definitely we can spill over the use of the immunotherapy in these patients to achieve the proper, more better disease control. That remains an option, so that can be tried in selected patients under proper supervision by the treating physician, and taking the patient also into cognizance, so that it is an affair where the decision is shared between a patient and the physician, and we can, from case-to-case basis, we can think of giving immunotherapy, because that has a big window in achieving a T-cell tolerance, because we know that allergic asthma is a T-cell disease. The only way we can achieve a T-cell tolerance is by the properly selected patient and the allergen, and giving in right dosage the allergen immunotherapy. Thank you.
Yeah, thank you, Dr. Saibal. And I would like to thank all the panelists for their generous comments and sharing their thoughts. And, it's very important for us to note when we look at all the guidelines that the guidelines are based on evidence. And when you look at evidence for the immunotherapy and look at the kind of patients they have chosen, all of these are mild to moderate asthmatics. You don't have too many studies on severe asthmatics. Maybe if they did, they would found it to be useful, and we would have a more evidence on the so-called risk-benefit ratio. So lack of evidence doesn't mean it is not useful. So I just wanted to raise this point that when we look at the guidelines and look at the evidence, if there is no evidence, it cannot come to the guidelines. So there are cases where we have gone beyond the guidelines. For lack of alternative, we have used immunotherapy even when the guideline says there is no sort of evidence. And I hope that the people who are listening to the program will be able to involve in research, and maybe there is a need for doing studies in severe asthmatics. And maybe then we will have some more evidence to know whether it's really useful, how much it is useful, what is the harm that can be generated, and the actual risk-benefit ratio. Thank you very much. I would like to thank the Indian Society for having given me an opportunity to moderate this session, and for all the eminent panelists for sharing their thoughts with us. Thank you very much.
Thank you so much, everyone, for sharing your valuable insights. We are more than grateful for everyone over here. So I would take a minute to introduce our platform, Planet. Thank you so much, everyone, for all of your patience, and hoping to meet you again.
Ankita, can you please share Andrela's video for vote of thanks?
Yes, ma'am.
Thank you, Doctor. I sincerely thank all our faculty, speakers, and moderators for taking out time to support ICS in this endeavor. As for our audience, thank you for joining us. Please feel free to write to us on icsofficeexecutive@gmail.com. Keep watching us. Stay tuned while we come up with our next webinar titled Adult Respiratory Vaccination on 13th of May, 2023. Please join us in large numbers, post your questions, and interact with our esteemed faculties. I thank our faculties again for making this webinar successful. We hope to carry forward these endeavors, and thank you so much. Thank you.
Thank you.
Thank you.
Thank you. Bye.
Thank you, everyone. Thank you, faculties.
Okay, thank you.
Bye. Good night to all.
Thank you so much, everyone. Thank you. Good night to all.
Thank you, sir. Good night, sir. Bye.
Good night, everyone.